Good afternoon, everyone, esteemed judges and the panelists. Thank you for this opportunity, sir.
Pola with pre-existing dehiscenc. The slit lamp examination will not reveal the real story. AIOCMT shows and confirms the diagnosis. Real story. AIOCMT shows and confirms the diagnosis. The slit lamp examination will not reveal the real story. AIOCMT shows and posterior pola with pre-existing dehiscenc. The slit lamp examination will not reveal the real story. AIOCMT shows and confirms the diagnosis. Patient taken for flags, CCC planned for 5 mm, and the posterior safety distance is increased away from the posterior capsule.
Can you pause it?
Yes.
No, what did the AIOCMT show? Was
So,
it an intact PC or
it was a breached PC. I'll just go back. So there is already a dehiscence in this area. I think
But there's no lens matter in the anterior vitreous area.
yeah. So we are not sure of the lower half. I mean exactly at the pole we were not sure of it. So that is why we decided to yeah. Yeah, it's very strongly adherent is what we thought. So during the case, as the events turned out, it turned out to be a the dehiscence was already there.
Confirms the diagnosis. All steps, CCC, fragmentation and clear corneal incision are done by flax.
That ensures a proper CCC. So
The capsule is pinched out. No hydro procedures are done. The corneal incision are done by, and the posterior safety distance is.
That's the safety zone.
Yeah, but you're taking it beyond the posterior.
Yeah, so we have extended and we have kept a safety zone above and below. Below doesn't matter. Above, we didn't want a very huge, thick epinuclear plate, but we have kept it to around 700.
What's that, on that right image, there is that pink line which seems to be what the laser thinks is the posterior
This is the
capsule.
OCT image that the machine has captured.
But what's that, why is that orange thing extending much below it?
This is a safety zone. It
Oh,
extends
okay,
above and
so
below
above
of
and
the
below,
laser.
so
It
right,
doesn't,
right.
yeah,
Got
the
it.
laser won't hit in that area.
Got it. It's different from the catalyst, that's why.
Yeah.
Increased away from the posterior capsule. All steps, CCC, fragmentation and clear corneal incision are done by flax.
So we went ahead with fragments and we did a CCC.
The capsule is
So
pinched
the
out.
CCC ensured
No
that
hydro
we
procedures are done.
support in
Bimanual
case
IA
of
is done directly.
with an
No
optic
rotation is attempted. Since
so
it is a soft
we
cataract, no phaco is really.
patient and there was not much nuclear matter. So in this case, we kept the bottle height and the parameters very low, considering that any fluctuations in the bag would lead to a drop. So since we had a thick epinuclear plate, it was slowly and steadily that we decided to peel off the nucleus, and without losing the bag integrity, we kept on injecting viscoelastic so that the bag doesn't collapse.
Most make sure that all the soft cortical matter around is as.
No cylinders, only 6 fragments, 4 fragments. No, that's the hydro dissection. Only
You can do
4
6
fragments.
jobs, but if you do cylinders also, 2 or 3 cylinders, then those pieces, they become like pies,
Which can be taken out easily.
So why did you use a phaco probe to kind of just take that skeletal material instead of doing a IO?
The nuclear material was very soft, so the chances of a crater being formed then further complications. That's why.
So you,
Before the
Dr.
central
Shivani,
part
you
is
always
angled.
keep your side port at in
Yes.
this location.
Yes. It's easy to maneuver 360 degrees. I mean, this is as per
No, but if
comfort.
it's 180-degree apart, I think
Yeah.
that gives a better access and give better centration of the eye also. Because but then there is no subincisional as such, So you need to angle your cannulas like
Yeah,
this.
yeah.
I can see that. Yeah. Okay, please go ahead.
So essentially, we were left with the central adherent PPC. So we tried to hydrate that area. We tried to slowly peel it off, but eventually it was going to tear, is what it seemed. So essentially, when you can see that the PC is being pulled along with the plaque. There are folds on the PC,
which are
and
soft cataract, and it can
yeah.
be
So
done
while it was
directly
coming
with
off, there was a dehiscence which we
all
saw.
the cortical remnants are removed. The plaque is
Can you
gently
pause it
lifted
here?
off.
Yeah.
Dr. Gaurav, would you like to go in visco
So
dissect?
exactly,
at
I was
this?
saying that never peel these things, never trying to pluck them or peel them. The best way is to just go into visco dissection, right? Even a passive flow of fluid like BSS also will sometimes float it up, but visco is the best because if you just start putting visco from various sides, it'll end up kind of separating it without any pull on the PC, because the PC tears, it's very thin and very also adherent. So the moment you pull it, it's going to just kind of break. But visco dissection works wonders.
And moreover, the visco is going to plug that defect
allow
which is
the-
there. Yes.
Coming to that,
Vitreous to
even
advance.
more than HPMC, I would like to use viscoat.
Viscoat,
in
yeah.
this, so that also tamponades the
Tamponades.
anterior space plus dissects the.
Please.
One can see that all the cortical remnants of the plaque is held with the aspirating port and all around gently elevated from its attachment. One can also see the dehiscence in the posterior capsule which is present and which was diagnosed preoperatively with the help of the AIOCMT3. The plaque is then detached completely. With the help of the aspirating port, the plaque is gently elevated and making sure that no vitreous is, with the help of the aspirating formation, with the help of the viscoelastic chamber is not allowed to collapse at all. And once that is done, we made sure that the vitreous did not follow the plaque. Since the rest of the capsular bag is intact, and in the bag IOL placement and rotation of the IOL is achieved. The rest of the cortical matter is removed once the lens is placed horizontally into the bag. So with the help of advanced technology like FLAX, let's look at the first day post-op image. You can see the lens in the bag and a well-centered IOL. Thank you.
Thank you.
Anything?
Which IOL is this?
J&J Hans.
No,
EDOF.
but there are holes in the. You created the holes?
No, it's EDOF. Yeah.
No, but did you create the holes at the haptic optic junction? They have holes. They are
No,
dialing
no,
holes.
there are nothing created. Maybe it
Just
was
see.
a.
I mean,
Yeah.
Posterior pola with pre-existing, since the rest of the capture is
see some
removed.
holes on the
Yeah.
haptic optic.
Once the lens is placed
no, it's
horizontally
Possible to
into the
specialize
bag.
to kind of anchor it.
So with the help of
No,
advanced
no, no,
technology
no,
like
no.
FLAX,
Maybe
let's look at the first day post-op
Be
image.
comfortable.
You can see the lens in the bag and a well-centered
No, I was thinking
IOL.
if just in case a single
Thank
piece
you.
lens, you end up needing to suture it, you can just pass a
a
suture through that.
Capture also with it.
Yeah, we could have.
Posterior axis with the optic capture, because that's a small PC
So,
defect.
would we do a PCCC in this case to? I mean, already the defect is pretty circular and there's no vitreous.
Shivani, if you go
Alright.
back to the end, no, there is a little bit of a traction on that round hole.
Yeah.
So there's possibility that there's a vitreous adhesion there. Sometimes that can cause traction at the vitreous base and it can cause a break.
Okay.
So perhaps maybe a good idea to actually put triamcinolone and
At the
check.
end and check.
Yeah, and if you have, then maybe good to do an anti-vitrectomy as well. And of course, you have to screen the peripheral retina and make sure there's no break.
Okay.
So wherever you see irregular tears,
Hmm.
you definitely have to do PCCC and make them regular,
Hmm.
so that it doesn't tear off in periphery, once you're putting IOL.
Yeah.
So that's the importance. You convert it into PCCC, and you go ahead and put a single piece IOL.
Harshal,
like this. Yeah.
in these posterior polar cataracts, capsule is so thin and
Yes.
very difficult to it's not very easy to convert them into PCC. So I'm
I
thinking that, whether it's a good idea to just leave it if it's a small one with some
No,
scarring.
but she had
But-
a small tear to begin with,
yeah,
but
true.
while putting the lens, it enlarged.
It enlarged.
So
yes.
had she had converted first, it doesn't enlarge.
I think she had been quite fortunate. Most often these PCC,
They
when
go
it
through
is
and through,
split,
yeah.
it will be one pole to another pole.
Yeah.
That actually is also a good thing in the sense that it doesn't extend. And you have two flaps of posterior capsule where you can place your intraocular lens. But in her case, it was a nice round
Yeah.
fibrosed rexus
Pointed
margin
out.
that was there. And what Rishi is pointing out, I thought there was more of striae on the capsule, but still I would always recommend that putting in a drop of triamcinolone and testing it. But we also started doing this routine use of ASOCT for all these cases. And a very thick plaque like this, even though there might be an intact PC, sometimes you are not able to make it out because it appears anechoic. It doesn't go through the very thick plaque. Secondly, you might sometimes have very tiny holes in the posterior capsule, because of which it appears deficient. Or it might be an extremely thin but continuous posterior capsule. You have to be very careful about it, but it's fortunately has a negative connotation in the sense that even though you might think that the PC is not there, we are pleasantly surprised that it is intact. But if the PC definitely seems to be intact, then you are on, and we nowadays start handling those cases like a regular cataract surgery where we go ahead and hydrodissect, rotate the nucleus and do everything.
So I think we've described the sign, the disc sign. So if the disc sign is there, that means the PC is intact. And second is if you do have intraop OCT microscope, and Gaurav would agree, then it kind of helps to refine your surgery better. But I agree with Dr. Ramamurthy completely that the kind of defect that was there, and the case was handled well, otherwise it could have gone into a better place also.
Very nice, Shivani.